Welcome to the CPQCC Hypothermia webinar. I'm excited to present our speakers who will be informing us on the latest for therapy and management identification of babies with hypoxic ischemic encephalopathy, and also go over some tools that can help us to manage these patients. We are going to be having a Q&A at the end, so keep that in mind as we hear our presentations. So our agenda today is first we'll have Dr. Dongli Song, who's the Eugene Kim Endowed Chair at Santa Clara Valley Medical Center and the director of their NeoNICU. And she will give us a presentation on the CPQCC early screening identification of candidates for neonatal therapeutic hypothermia toolkit. And then we'll have a presentation on current updates on HIE management from Dr. Krisa van Meurs, who is professor and Rosemary Hess Endowed Chair at Stanford. And then we'll get some really neat presentations of tools that are available already in cool tool from Tom Shimotake, who is professor at UCSF and director of the NICU there, and the president-elect of CAN. And then the NeoCool tool by MJ Harbert, who is at Sharp Mary Birch Hospital and director of neonatal neurology at Sharp. And then we'll end with a Q&A moderated by Dr. Priya Jeegatheesan, who is the chief of neonatology at Santa Clara Valley Medical Center. I do feel like really lucky that in California we have all of these experts who have been really leading efforts to better care for our patients with HIE. So yeah, please, even during the presentations, if you have questions or comments, you feel free to chat those, and the panelists will see them. We'll collect them for the panel Q&A at the end, so we won't answer them during the presentations, but we'll be watching out for them and try to answer as much as we can toward the end. Next slide. So yeah, you are muted. So use the Q&A box, please, if you have any technical difficulties and/or submitting questions you have for the presenters. And we will be recording this, and so please share afterwards with your colleagues. Next slide. All right, I'm going to hand it over to Dr. Song.
Okay. Hi, everyone. Can you hear me? Yes? Okay. I'll try to raise my voice because I always have that issue. Welcome to this webinar. I think the first one I'm going to talk about and start with this webinar is really go through the CPQCC toolkit. I'm hoping everyone already is using it, and we'd like to have some time for you to share your experience and your comments on the toolkit and how you're utilizing it. So the toolkit was published in 2015. At the time, we well recognized that hypothermia therapy, and actually if initiated in a timely fashion, can significantly improve survival and neurodevelopmental outcome in neonates with moderate to severe HIE. And also at the time, we recognized some of the babies who can potentially benefit from this therapy may now be recognized and being actually referred or being pulled. The one emphasis for this toolkit actually is to recognize that those screening criteria, those are screening criteria only. They really meant to improve early identification of at-risk babies who might warrant closer assessment. And they are not really designed to be the inclusive criteria for pooling. This toolkit actually can be downloaded from CPQCC website. So objective for the really toolkit is to provide a standardized approach and reliable tools to assist the birthing hospitals in the timely identification of newborns that are potentially candidates for therapeutic therapy. That's including the centers, even they are doing cooling. Usually the babies are born and being taken care of by frontline providers. They are not necessarily the physician who actually performing cooling. So the screening criteria. The first set, the toolkit really designed for a baby who born equal or greater than 35 weeks gestational age, less than 6 hours of their life. And if any of those babies have any of the following factors can trigger further evaluation. The first one is a history of acute perinatal event and the risk factors. And that's including quite a broad, kind of a long list, placenta abruption, port prolapse, uterine abruption, fetal bradycardia, prolonged rupture membrane, fetal heart retracing, not reassuring, sick meconium, tight novel cord, field vacuum delivery, then actually there are probably more factors. Whatever the factors can make this baby and actually at risk for a good transition, it will be considered. And the second part is the APGAR, and we put it here as APGAR less than or equal 6 at 10 minutes. And many of those babies actually needing a continued positive pressure ventilation, or even have a history of CPR. The last piece of this screening criteria is actually the blood gas, the cord blood gas. Even though we traditionally use cord arterial blood gas, and here listed any cord blood gas, recognizing sometimes a cord blood gas actually obtained, we think is arterial, maybe it's not necessarily arterial, and some of them both are arterial or venous. And baby's blood gas, especially in the cases where there is no cord blood gas available. So baby blood gas within the first hour of life becoming very important. The cutoff we put here is pH less than or equal of 7 or base axis less than or equal -10. Here actually it's in Appendix A. It really outlines the process of how to do this. The timeline here is the baby born. Within the first couple minutes, the frontline physicians or whoever in the delivery room are receiving this baby should be able to recognize a couple of factors. One, if the baby's APGAR less than 6 or equal or less than 6 at 10 minutes, meaning this baby have some difficulty with transition, have a history of acute perinatal event or even some risk factors to put them in a position potentially have a difficult transition or having a period of a lacking of oxygen and perfusion. Or, and in fact, the babies will require continued PPV at 10 minutes or even needing CPR. And then to ask your OB doctor or fellows to get a cord blood gas. Maybe we're not able to obtain a value at 10 minutes, but at least to asking the OB doctors to obtain the cord blood gas. And the next, so that's the initial trigger, initial phase to quickly recognize who will need to be assessed. Once we pass the first run, decide which baby need to be assessed, and then we actually performing evaluation. But this evaluation actually need to be targeted, not very prolonged. So here we put in 10 to 60 minutes within the first hour, essentially. So we need to request cord blood gas. We actually need to get the value of the cord blood gas. So the cutoff is less than pH less or equal of 7 or base axis less than equal -10. And then also, regardless, I think in most centers, including us, whether you have a cord blood gas or not, we would like to have a blood gas from the baby within the first hour of their life. It can help you in the case where you do not have a cord blood gas. It's also very helpful. Even you have a cord blood gas, here you can have a sort of a more dynamic information regarding the cord blood gas, the direction it's going. And the one key point during this period of time is perform targeted neurological exam using a chart. We will review it in the following slide. Of course, some babies, maybe even at a stage, they can have seizures and need to be observed closely. Once this targeted evaluation is done, hopefully will be done by first, say, half hour or hour, and then initially call to the calling center, or say if you are actually at calling center, but call to the NICU, to the neonatologists who are normally doing the cooling, to initiating a conversation and to discuss the assessment, the evaluation, and also if the decision to make to arrange for transfer. This is the neurological exam actually in the appendix, and it's based on the SANA. I put it as encephalopathy, classified as mild, moderate, and severe. I think this is actually one of the critical point in terms of decide whether this baby should be cooled or not cooled, whether they have actually encephalopathy. But I think unfortunately, many of the pediatricians and including neonatologists have not done very solid training during our training or even during our past experience. So to have a standardized neuro exam and being trained and actually have a continued education in all the birthing center for all the pediatricians or neonatologists or whoever actually going to encounter for initial evaluation of those babies, they need to feel comfortable to perform this. And this is going to be I think it has been an ongoing process, as even including our center, we've done this for more than 10 years, or starting 15 years now. We still feel there's a lot of room to improve on this. And there are some resources actually to have video YouTubes available for how to do proper neuro exam on newborns. I think I really highly encourage everybody to go through it. And I'm thinking of at some point, maybe we should have a kind of a certified process for this so that everyone, the frontline physicians feel comfortable and feel confident they are doing the right thing. But specifically for this neuro exam, if a baby is have a very severe encephalopathy, I think nobody actually knows that. Everybody can recognize it. The challenging has been many babies fall between mild to moderate. And here the table listed seems much more clear cut. You either have mild, you have moderate. In fact, many of the babies can have some components of their exam is mild, some of them have moderate, and some of them start with mild, become moderate, and some maybe seemingly was moderate in the delivery room or soon after birth, and gradually improve, become mild. I think this has been an ongoing challenge. And then Krisa is going to talk a little more about how do we deal with the mildly affected babies. And here, I think I put a slide here because it's in the our toolkit, but the label under the label of a passive cooling, maybe it's a little bit misleading in this sense. I think really what the mandate should be is how do we managing those patients while we are having a communication with the referring center, and while we are waiting for transfer, or while we have decided that those babies are no longer need to be, they can basically pass. They do not need to be cooled. So put that in the mind, and the first thing we need to remember is to document regional cooling center contact and decision made to initiate passive cooling for those determined to be a candidate for cooling. So really this temperature management in this toolkit is meant to be for the babies who are already at the first round of a communication that has been decided this is a cooling candidate. With that in the background, and if that's the case, then the referring center or whoever managing it can have a series of temperature management. And the goal of this period of time in terms of temperature management is try to avoid overheating the babies because we know based on previous studies, the baby who got overheated, regardless whether they are cool or not, they have a worse outcome than the ones who has maintained the temperature in the expected range. For that, I think a continuous temperature monitor will be ideal. Otherwise, every 15 minutes to to measure it manually is also acceptable if you don't have a continuous management. Because this is actually geared for the babies, managing babies who already being determined to be a candidate for cooling, so the target temperature end up as 33 to 34 as a core temperature. Yeah. So in this case, and here it's recommended to turn the video warmer off and leave the baby uncovered. But this is, again, this is not for all the baby we're evaluating. It's the baby who are going to be sent transfer for cooling. The next part, I think that I noticed there are a lot of nursing staff in this conference, and we have heard a lot from our nursing staff is, what if the baby's temperature actually much colder than this, being overcooled? We can have this discussion if we have time at the end. I think this is something we have in the toolkit kind of mentioned it in 13 ways to manage it, but we are open for discussion. In the meantime, the toolkit tried to gear saying, because we're evaluating those babies, the criteria for evaluation actually is very broad. Many of those babies probably do not need to be cooled, but they actually have issues. So when we are waiting for transfer, we should not forget continue monitoring their vital signs and pay attention to whether they have infection, they have other issues. If they are on the respiratory support, they will try to avoid hyperoxia or iatrogenic hyperventilation. Try not to talk too much about it. What's our time now? Okay. I think we probably can open up the discussion or talk about more. Okay, the end. Okay. So the presentation, if we talk a few more things, I think this is probably open to need a lot of input. Essentially, one most important part in this continued evaluation is to do ongoing neuro exam. Even with a normal exam or an abnormal exam at the beginning, when the referring center communicated with a cooling center, and the neuro exam can change over time, and that has to be sort of have a continued monitoring on the neuro exam and ongoing dialogue with the cooling center. And in the meantime, and whether those babies, when they are not qualified for cooling, and we definitely think that they should be warmed up and sent back to the mother, there's other additional management steps. And one of the things I noticed probably a lot by nursing staff is when we doing our evaluation, if we actually turn off the warmer, or we not try to keep them temperature warm enough, the babies who being affected are mild affected. They can actually drop their temperature and getting cold. If we decide that this baby actually do not need to be cooled, and there will be some process actually let them to back to their normal temperature. Overall, I think the strategy is using the strategy where we know how do we normally keep those babies have their normal euthymia. That's the strategy. Whether we should considering NPO or not, whether we should feed them, whether we should considering other blood work, including sepsis workup, I think this all fall into our regular standard of care. And this, we put a lot of things here, but I really think this important thing is to make an early decision whether this baby need to be cooled or not. When they decided they need to be cooled, we need to manage their temperature properly and also pay attention to other vital signs and needs. And if the decision is not to cool this baby, and then we also having some standardized process to kind of bring them back to their normal well baby care status. We have one slide, I put one slide here, it's actually our experience. We have done this, summarized our data from year 2008 to 2018. Over this period of time, we have over 40,000 baby delivered. Actually, the bottom line is we have a little bit more liberal screening process and end up 4.3 babies being screened. And only less than 1% of those babies actually brought into the NICU that gone through this very thorough evaluation. And among those who were evaluated, 20% of them got pooled. At the end of the day, is 1.5 per thousand of babies being pooled, actively. I think I'm going to end here.
Thank you, Dongli, very much. And yeah, next we'll transition to Dr. Van Meurs, an update on HIE management.
Okay, next slide.
Sorry, give me 1 second to sort this out.
My name is Krisa Van Meurs. I'm going to be talking about management of HIE. And I think the next slide, or move to the next slide, I've got an agenda of what we're going to cover in the next 15 minutes. Hopefully that'll come up. Yeah. So
I'm sorry, I keep telling it to play from the current slide and it keeps going back to the beginning. So let me.
Yeah, it does do that.
Go right ahead.
Yeah. Okay, so we're going to first talk about some completed randomized trials, then go on to some updates on trials that have either ongoing or recently completed, and then talk about some management publications that have been recently published. So next slide. I'm going to first talk about the late hypothermia study, and this is a NICHD trial that was published actually in 2017, but is something that people frequently ask questions about. And this was a trial that enrolled babies between 6 and 24 hours of age that had met the original NICHD criteria for moderate or severe encephalopathy, but didn't get treated before 6 hours. So these babies were cooled at 33.5 normal temperature for cooling for 96 hours instead of 72, or received sort of controlled temperature management. And then were followed up at 18 to 22 months. And the primary outcome was death or moderate to severe impairment. 168 babies were enrolled. Next slide. You might wonder, should a baby be cooled after 6 hours? And this can happen frequently. I think hopefully less so with our toolkit now. So babies arrive, don't get to a cooling center until after 6 hours of age, or they're seen to progress from mild to moderate or severe after 6 hours. And again, that can happen. And then babies are just not recognized to qualify until later, or if there's some equipment or personnel problem. And again, I want to emphasize that we really, to get the best results, want to cool babies at less than 6 hours, because that's our therapeutic window that has been shown to be most effective. Next slide. Shown here, and I won't spend much time on this. Again, this is a trial that we knew we weren't going to be able to find a lot of babies. And even though 21 network centers were involved over a 6-year period, we only got 168 babies. And so the p-value for the frequentness analysis is not significant. And we knew that that would be true. But in a Bayesian analysis, you can see I've highlighted that 77%. Next slide. So in a simplistic way, that the outcome of the trial shows that babies that were cooled for 96 hours, 77% of them benefited from that late treatment. Certainly not as effective as early treatment. Next slide. Moving on to another question that I think as neonatologists and neurologists we've been very interested in is what drug is the best one to use for neonatal seizures. And this trial, I think it gives us some great information. And there haven't been a lot of trials of anticonvulsants with neonatal seizures. And they compared levetiracetam or Keppra versus phenobarbital. And the objective was to determine which drug was more effective in treatment of neonatal seizures. The primary outcome was defined as being seizure-free for 24 hours. If you look at the authors, you'll notice that we have quite a few California authors that were involved in this trial. So thanks to them for these results. So next slide. So this shows the design. So once electrographic seizures were detected, the babies were randomly assigned. And again, in the allocation, instead of the 50-50, was actually 60% went to Keppra and 40% went to phenobarbital. And as you can see the strategy. If you were going to get in the phenobarb arm, you first got 20 milligrams per kilogram. And if the seizures were not controlled after the infusion was complete, and after a 15-minute period, you got an additional 20 per kilo. Levetiracetam, you first got 40 per kilo and then 20 per kilo. Now, if those didn't work, and you can sort of see the times down the middle, you crossed over to the other arm. Next slide. Results were very clear. As you can see, the primary outcome, 24-hour seizure cessation rate for phenobarb was 80% compared to Keppra at 28, P very significant. They had some secondary measurements, 48-hour and 1-hour cessation rates. Again, very significantly showing that phenobarb did a better job. They also did a sub-analysis in babies with HIE, because then that was about 50% of the population. And again, phenobarbital control gave patients with HIE, 90% of them 24 hours seizure-free compared to Keppra as the first-line drug, 35%. Next slide. So again, very clear results. They did state that they saw more adverse events, things like sedation, need for respiratory support, hypotension with a phenobarbital arm. But again, the difference was not statistically significant. But again, the numbers are not very large, so that can happen. They did notice that with levetiracetam, with the second dose, they got a little bit a better bump in their seizure-free period. And they suggested that we need to do studies with higher doses of Keppra. And then also, as in with a lot of things, that we'd love to be able to see long-term outcome results of this management strategy. Next slide. Now I'm going to move on to the studies we don't yet have results on that are going to be coming soon. The first one is the NICHD preemie hypothermia trial. And this was for babies 33 to 35 weeks. It used very similar entry criteria to the other network studies. Babies were cooled for 33 to 33.5 or 72 hours and then slowly rewarmed. Same primary outcome, a Bailey exam at 18 to 22 months. And then the primary outcome was moderate to severe impairment or death. Again, this was a trial we didn't expect a lot of babies either, using a Bayesian analysis. And this trial was completed a little bit more than a year ago, and we're well into the follow-up phase and should have results in about a year. Of note, in the you'll notice the overlap with the Cool Toolkit with the inclusion of babies at 35 weeks. When Abbott Laptalk, who's the PI on the study, called all the investigators of all the large trials, he found out that there were actually only 7 babies that were cooled at 35 weeks in the randomized controlled trials. But so certainly this data is going to be very important for us to know if we should be cooling babies within this gestational age range. Next slide. I think as something we're all aware of, despite the great impact of therapeutic hypothermia, there's still a lot of babies that don't benefit. And here is the aggregate results of the cool arm, showing that we still have a significant rate of death, disability, and CP in babies who are cooled. Next slide. Here are some of the potential drugs that have been thought about in animal studies done as potential cooling plus therapies. And I highlighted in red some of the ones that have actually more results or in humans. Next slide. In this limited time, I'm just going to focus on one. It's erythropoietin. We usually think of it as a drug that helps Patients make more red blood cells. It also provides neuroprotection, has some acute effects, neurotrophic, anti-inflammatory, anti-apoptotic, and antioxidant, and then some long-term benefits helping brain repair, as shown on this slide. Next slide. So the HEAL trial, high-dose EPO for asphyxia encephalopathy, was completed enrollment completed about 2 years ago, and now the follow-up phase is also complete. And you can see that the design of the study, very similar primary outcome, death or moderate to severe impairment, and some secondary outcomes, of course, safety, MRI results, and biomarkers of brain injury. So there will be trial results coming, quite soon for this trial, since we have completed enrollment and follow-up. Next slide. I'm going to talk now a little bit about mild HIE, and this is a figure taken from Joseph Volpe's Neonatal Neurology. The previous information was that babies with mild HIE didn't die, weren't disabled, and they all end up normal, which unfortunately we found subsequently is not the fact with more studies. Next slide. So what's the current practice? And again, there's been a lot of therapeutic drift. People realize that therapeutic hypothermia obviously benefited a lot of babies, especially those moderate babies, and I think they have been hopeful that it would benefit mild babies. And as you can see, the CHND, Vaughan, and CPQCC have all found that people are using therapeutic hypothermia for mild HIE. There are various definitions of what people call mild HIE, as I've shown on this slide, as far as how many SARNAT abnormalities and what kind of other criteria are used. Next slide. I don't have enough time to show you all the information. This is from the PRIME study done by Lena Shalek and others. And these were babies that met the NICHD criteria and then had more than one modified SARNAT abnormality, but were not cooled. So it gives you what sort of the baseline, what happens to these children. And as you can see, 52% of them have an abnormal short-term outcome, and that is either abnormal AEG, MRI, or discharge exam. And at follow-up, 16% of them had disability. Next slide. We don't really have any randomized controlled trials that are completed yet, and I think many of you know that we're in the process of performing the TIME trial, therapeutic hypothermia for infants with mild HIE. You can see the participating hospitals listed on the slides. All of some of our California colleagues that have been so great to join us in this endeavor. Next slide. In this, the specific aims are to determine the best approach to identify, consent, and randomize term babies with mild HIE. They're a much more difficult group to identify because they're obviously not as impacted as babies with severe HIE. And we're going to also look at safety and then also outcome results at 1 year of age using the WIDEA and the AIMS exam. Next slide. I'm just, again, these babies will be cooled in a very similar measure, in a similar manner as in the other trials. Next slide. I'm now going to just talk about 3 management strategies that I think people are going to be interested in. And the first one is seizure during rewarming and outcome. And because I think we all have different periods of time where we do AEG or video EEG in a cooling center. And this is a cohort study from babies enrolled in the Optimizing Cooling randomized controlled trial. And so Lena Shalek in this compared the AEG tracings during rewarming to the 12-hour period before rewarming. And what she found is that during rewarming, 27% had seizures versus 14% in that pre-rewarming. So certainly there's a higher risk of seizures during rewarming. And when these babies seize, they have a higher risk of death or disability, as you can see with the relative risk of 1.7. So I think it's important to continue AEG or video EEG through rewarming. Next slide. Feeding during cooling, also something that I think that many of us have been thinking about, because we know that potentially or theoretically these babies might be at higher risk for neck, but we also know there's beneficial effects of enteral feedings after HIE. And looking at some data from the National Health Service over a 7-year period, they had 6,000 babies that got therapeutic hypothermia. A third of them were fed. They only saw neck in 7, so very low number. And in a later study, the rate of feeding during hypothermia had increased to 59%, and it also increased as the babies they went from day 1 of cooling to day 2 to day 3, and babies were less likely to be fed in a couple situations if they had severe HIE, were on inotropes, or had an elevated lactate. So I think in selected infants, feeding during cooling appears to be safe and not associated with increased incidence of neck. Next slide. Anti-seizure medications that discharge. Hannah Glass has been working on this topic for a while, and it's a very controversial area. We know that about 10% of neonates with HIE develop epilepsy, and the highest risk is in those who have neonatal seizures and abnormal brain imaging. So of the babies with neonatal seizures, 25% are going to go on to develop epilepsy, and the highest rate is in those with status epilepticus or severe brain injury. Hannah is part of a neonatal seizure registry that I think she spearheaded, involves, I believe, 8 hospitals. And in their registry, 64% of the children had continuation of drugs after discharge, but the epilepsy rate and functional neurodevelopment were similar. So from this, these results support discontinuation of these medications prior to discharge in most infants with acute seizures. And again, this is an evolving practice of neonatal neurologists. Next slide. Okay, I'm just going to mention some resources if people are interested in some of these topics. Sonia Bonavasio and other members of the Newborn Brain Society have 2 issues in seminars of fetal and neonatal medicine. One that talks about daily management of neonates, and then the second issue on unanswered questions. Next slide. Also, the Newborn Brain Society Education Committee that I'm part of has weekly webinars on topics related to neonatal neurology. And these are free. They're on Thursdays, 9 a.m. California time. And they've been ongoing for about 2 years. And you can see the address of the Newborn Brain Society to find out more about these. Next slide. Last, be aware that the upcoming International Newborn Brain Conference. This was previously called the Brain Monitoring Conference that jumped between Florida and Cork, Ireland. And this year it's going to be both in person and virtual, February 9th through 12th. Next slide. Thank you very much.
Thank you, Krisa. We're going to transition now to the cool tool presentation by Dr. Shimotake.
Thank you, Henry. Let me share my slides here. Can everybody hear me? Is this and see my slides?
Yeah.
So I'll try and just run through a demo really quick based on a case, just a little background. We developed this screening toolkit kind of as an offshoot of a group that we developed with Northern California cooling centers. And then we had a working group, a subgroup, to try and develop this toolkit that included Priya and Krisa, as well as Dongli, as well as Anna Morgan from Kaiser Oakland, which was released in 2015. And then in 2017 or so, I met this graduate student who was working in the certificate program for implementation science here at UCSF, and developed this project idea for decision support tool based on the cool tool, the screening kit. And It seemed like it would be pretty straightforward based on the algorithm, but in implementation, it we learned quite a bit about what providers and nurses and staff actually find useful. So we did interview a lot of providers in hospitals, and so there were multiple iterations. But the goal was really to provide an easy to use, openly accessible decision support tool that people could use in the middle of the night to help them make a decision about whether a baby was a candidate. The majority of these babies seem to be born in the middle of the night, far away from a large tertiary care center. So those are the babies that we're trying to capture. And it may be an OB nurse at 2 o'clock in the morning trying to decide whether they have to wake up a family practice doc to come in and do an exam. And we want to help them get over that activation energy by giving them something to base their decision on. So you can do a Google search for the CPQCC toolkit, takes you right here. The HIE calculator, which we nicknamed the cool tool, is down here. And you can click on that. It'll take you to the site that'll look like this. And it's got a field that you will basically just enter based on your clinical scenario. This is the clinical data field, and this is again based on the algorithm that we're all familiar with. So you will start with a baby whose term. This is basically just a scenario we're probably all familiar with: 3 o'clock in the morning, an emergent C-section, term baby, severe prolonged decels, cord prolapse perhaps. In this case, it's a community setting, so you're waiting for anesthesia. An emergent C-section is performed under general anesthesia, and the baby presents limp and bradycardic. You go through your resuscitation, you provide bag mask ventilation, escalate to 100%, but the heart rate is still low. So the baby starts to receive chest compressions for 1.5 minutes or so and gets intubated. So these are all known risk factors for HIE, and these are sort of flags that we're picking up on in this toolkit. The APGARs are assigned as 1, 1, 4, and 6 with asterisks for intubation, but the baby does not receive epinephrine. So now we can take that data, enter it into the field here. It's a full term or greater than 35-week gestational age baby who's only an hour of life. There was cord prolapse, there was severe fetal bradycardia. We have an APGAR at 10 minutes of 4. We don't have gases yet at this point, but we can fill out the rest of this field and say there was CPR and need for continued ventilation at 10 minutes. So all of that is correct, but the pH we can leave blank for the time being, and then click on determine recommendation. It's going to highlight in yellow those fields that are potentially meet criteria, and it will open up this neonatal neuroassessment tool, which will initially register as unable to assess. But this is the one of the more challenging aspects of trying to identify babies for cooling is the neuroassessment. And so we all have our spreadsheets of the Sarnaut exam, but having some video demonstration is actually really helpful, we find. So that's what's embedded in this, and we have some additional information if we continue on with this scenario. We have an initial UA gas that doesn't look too bad, 7.2 - 8, but we know that that can also be not accurate if there's a problem with compression of the cord or blood flow. And the first patient gas does in fact meet criteria at 698 - 15. So now we go back to our tool, our neuroassessment tool. We enter in the age, we enter in whether seizures were observed or suspected or confirmed, and then we can start to fill this out. Again, this tool is based on a neuro video library that Courtney Wistoff developed. You can also go straight to the website and just click directly on the neuroanalysis tool bar at the top, and it'll take you right to this assessment tool. So you want to click on those things And again, this is Courtney Wistoff's library, plus we've embedded some of the additional videos from Paul Larson and Suzanne Stenhouse's PD Neurologic Exam videos. But I'll do a quick demonstration here of what this looks like. I'm going to stop sharing here and go to video library and show you what these videos look like. They're quick, 15
This
seconds.
neonate has moderately abnormal posture. You see strong distal flexion in the closed fists and at the ankles, yet the legs themselves are extended.
So again, very brief, to the point. When you click on the exam finding you're looking for, that's what you'll see. So in our exam, this is what we're seeing for this baby. We're clicking on those fields. And again, you can click on the video link to confirm what you're seeing. And then at the bottom, you're going to print a report, and then it will generate a recommendation. In this case, this baby meets criteria for moderate to severe risk factors. And so you should refer this baby to a cooling center. Now, there are a couple options here. You can print this report. And again, it's a neuro assessment, and it has the option to enter in additional comments and to put a time signature on this. So you can do serial exams, because we know that these exams change over time, and you can do these repeatedly. This is HIPAA compliant because none of this data is stored, and you're just printing this and then clearing it basically, and printing a new report for your next exam at a later time point. So other resources that are embedded in here, if you click on the Find a Regional Cooling Center, it will connect you to a map with all of the cooling centers in California. And this was recently updated. You can click on a center, and it will take you to that center and provide you with contact information for that hospital. So whatever cooling center is in your region, they should also give you that information. The other thing you can click on is the resources, other resources, protocols. And these are additional sheets with the tips for management and stabilizing patients, how to initiate passive cooling, how to manage babies who might have qualified but didn't meet criteria. So you still want to watch those babies closely, and this gives you some information about that. And then flow sheets so that you can keep track of the data on how these babies do. So I'm going to end there. I know we are running short on time. I want to leave some time for questions at the end, but the list of collaborators is long from multiple centers in Northern California, and we appreciated everybody's input.
Thanks, Tom. So yeah, we'll move to our next innovative tool presented by Dr. Harbert, NeoCool.
Hey everybody, I'm going to share my screen 1 second. Okay, can everybody hear me?
Yes, good.
Okay, thank you. Good afternoon. I'm going to demonstrate the NeoCool, which is a mobile app that is intended for outside hospitals, not cooling centers, to screen for potential cooling candidates. And this actually all got started way back in 2011. I started practicing neonatal neurology as my first faculty gig at UCSD, and I was seeing patients at Sharp Mary Birch and Rady Children's Hospital. And San Diego has a huge birth rate. We rapidly noticed that all of our outborns who are coming in from outside hospitals, particularly the ones that only delivered a handful of babies per year, let alone one with neonatal encephalopathy, those babies tended to do way worse from a neonatal encephalopathy perspective, and they were far more likely to be missed for potential cooling because everybody would get distracted by the pulmonary status or what have you, or if they didn't, in some cases, they weren't even aware that cooling had been an option. Even though for most of those institutions, cooling had been standard of care since between 2006 to 2008. We formalized those findings in a publication earlier this year that I'm just going to point to on the lower left. This led to our first pancake of an attempt, which was a laminated flip card with stick figure drawings that I did, that we passed out to all our ALS and nursing staff that would go to newborn resuscitations at our referring centers, as well as Sharp Mary Birch. And then later on, we converted that. We decided to convert it to a mobile app, which is Neocool. For those of you who use iOS, as most people in healthcare actually do, Neocool is in the App Store, it's free. I secured funding to do this app in 2014 through the Hartwell Foundation. And so that's thanks to the Hartwell Foundation, that's why it's free. They funded the development of the app. And there's no ads. We're not profiting off this or anything. So when you use the Neocool app, this is the first screen that you see in the middle, and then the one on the right is your pre-screening prompt to get cord gases. Because if you notice on the left, our outborns were far less likely to have cord gases, even though with education on our part, that's gotten better. Once you get through all the disclaimer screens, and there's the classic medical legal disclaimer as well, you'll see the screen on the left, which gives you the opportunity to tap new entry, which is per candidate at risk, review entry, which will gather all of your information at the end, and then FAQs, which includes information both about therapeutic hypothermia and the app itself. The center screen is what it takes you next to for new entry. It does ask you to input time of birth. It does not keep that information. The app doesn't actually retain any of the personal health identifiers, so it's also totally HIPAA compliant. The only reason it records the birth time is so the app can alarm when it's time to do serial neurologic exams at 3 and 5 hours of life after the initial one. Location is by state. Attendant is doctor versus nurse. On the right is the criteria that we're all familiar with, and I'm not going to walk through each one in the interest of time, but it's all does this baby qualify? Are they term? Are they less than 6 hours old? Been there, done that. Once that baby is determined to pass the original round of criteria, there's some input about the mechanism of delivery as well as the extent of resuscitation received by the baby. And then the second criteria on the second screen from the left, how acidotic is this baby? And so provided that the baby meets all of the A and B criteria, the app will either tell you to proceed to the serial neurologic exams, or tell you the baby doesn't qualify for cooling, but you might want to call your referring center just in case. Because obviously, even if these outside centers have concerns, we don't want the babies languishing out there. We'd like to have them brought to our attention. Okay, so this was the bread and butter of the app, actually, and that's for those of you who like a flip card format. I'm happy to send it to you. We've been using it for years. Now that we have several years of the flip card format under our belts, we're actually undergoing a formal analysis of the data now. But it's all right here in case you're not a flip card person. You'll recognize the elements of the SARNOT exam. I should note a key difference, though. This is actually not the SARNOT exam. One of the problems that we found with our outborn kids was the lack of training. And for San Diego and multiple other catchment areas, it's impossible to train all of your referring hospitals, especially if your catchment area covers parts of 3 different states like ours does. So what we did is we converted the whole thing as best we could into lay language, yes or no questions. And the goal here is not to diagnose encephalopathy and certainly not to grade it, but to just serve as a safety net. So if there are concerns from the outside hospital, they can go through it quickly and at least get all of the information down that they need to have in hand when talking to their transport center. So you can see our spontaneous activity. Next on the right is level of consciousness, posture. But if you look at the nitty gritty, they're not the same descriptors as the SARNOT. and then tone. We needed something self-contained that clinicians could go through very rapidly. We wanted this not only to be applied for nursing staff in a delivery room, but also anybody else who might be in the position of delivering a baby, like a midwife or a paramedic or the odd taxi cab driver, which happens not uncommonly right outside our hospital. These 5 screens from the app are the remainder of the clinical exam. And then you'll see the autonomic questions, heart rate and whatnot, with the last question being about seizures. Do you suspect it, yes or no? All of this, if you're going through it fairly rapidly, should take about 5 minutes if you're just reading through it for the first time. So we beta tested this with members of the lay public, as well as clinicians from all the rank and file as well. So you get through your first exam, and you will be met with one of these 3 screens. Either it's the one on the left where your baby doesn't qualify for cooling, but it will still prompt you to call your cooling center. Wait for the next exam, in which case it will co-opt the iOS alarm system to alarm you and tell you when the baby needs another exam. Or the baby may meet criteria for treatment. That means that they've had 3 abnormalities at minimum on the yes or no exam that you just saw. And it prompts you to call your cooling center and then to go to the review entry section so you have all that information at hand. And it's been so great to see where this has come from. I mean, this was all spurred by an app that was developed by the adult neurology folks that was designed to look at stroke thrombolytic administration, because they were running into the same problems that we were from an outborn standpoint, except applied to the world of adults. And it's been really fascinating to see what else this has grown into. There are a couple other institutions that have some therapeutic hypothermia screenings. One is from Alberta Health Services, and I saw another one just recently at UPenn. And I'm happy to take questions. Thanks.
Thank you, everyone. Thank you, Dr. Harbert. Actually, I'll just ask you a quick, easy question, perhaps, that came up. Is the NeoCool app only for iPhones?
So it actually works for iPads too. And we were worried about the barrier to entry, because even though we know that most doctors and nurses are statistically more likely to go with iOS, and the reason that I know that is because my husband is the Vice President of Research and Development at Qualcomm. So that was purely by chance. But it does work for the iPad. So if an outside hospital is looking for just a way to deploy it cheaply, they can just get an iPad and have it for dedicated use in their delivery suite. Android development is forthcoming.
Okay. Let's see. Priya, you want to go over some of the questions? You ready?
Sure. Thanks, Henry. There's another question, and I think this is a very relevant question that most of us struggle with. If you have neuro exam that improves when you're evaluating the baby, which neuro exam do you use to decide whether to cool or not to cool? I don't know, I think all 3 of the speakers or 4 of the speakers can perhaps share their thoughts on this question. Dongli, do you want to go first? Yeah. I think we have talked about this actually at our Cool Summit quite a bit, at the one meeting in particular. I think the sense I get to walk away the consensus that, first of all, we are in general taking the worst exam, but we also recognize at the beginning, the first hour of a life, baby have transitioning. So we more or less thinking at about an hour of life of what is your neuro exam. And I will let other speakers elaborate on it.
Yeah, I agree with that. And again, that's what one of the most recent trials, the HEAL trial, that's what they did. The earliest neuro exam they accepted was one at 1 hour. But again, if the baby at 2, is abnormal and meets criteria at 1 hour, just because they look better at 2 hours, you don't stop cooling.
Yeah, the distinction I would make from the clinical trials is that clinical trials do have that protocol for 1 hour, whereas a baby may clearly meet criteria before an hour and you can get the ball rolling. The whole idea of the cool tool was that we would give people who are on the front line some tools to make that decision, to pull the trigger on a decision to call a cooling center. So again, most of these deliveries are happening in community birth centers that are not tertiary care centers with 24-hour staffing. So, you may have a nurse who's trying to make this decision, and anybody can use these tools. The cool tool is anything with an internet access, so a computer, a phone, whatever. Yeah, and you can run through those criteria, and if they meet criteria, that's not, again, criteria that the baby will be cooled. It just means that it's justified to call a referring cooling center to discuss it, because that's where the final decision has to be made. But the sooner you can get that ball rolling, well before that 1 hour mark, the better.
Yeah, I just want to emphasize that I think it's, probably not a great practice to like cool and then later change your mind. So I think it's really important for the cooling center to interact directly with the treating physician or nurse practitioner or whoever's at the outside facility, and to walk through the criteria or use some of these tools to clearly determine, does the baby meet criteria? Certain babies are really easy. The very severely encephalopathic baby is an easier decision. Some of the babies that lie between mild and moderate are more challenging. And again, I think there's going to be a lot of benefit between of discussion. Often we actually nowadays take videos on our iPhones and they send it to us. And I think this hasn't been sort of validated as an accurate way of doing it, but I think sometimes can be quite helpful, especially if the referring provider is not, is maybe a family practitioner or someone that's not used to doing a neuro exam on a baby.
When I'm training our outside hospitals, I always tell them to go with the first exam that qualifies, and that waiting to initiate therapeutic hypothermia is going to do nothing but put them in more medical legal trouble. Also, piggybacking on what Krisa was just saying, I think that given the fact that there's no accepted terms for when you should stop cooling early, no outside center should be making that call. It should always be under discussion with the cooling center in question, and that cooling center needs to really document their rationale for stopping cooling early.
Thank you, everyone. I just want to mention one thing, and the Cool tool does have a resource of cooling centers in California that is part of the tool. And thank you for those of you who've sent in some updates, and we are trying to keep that up to date as possible. One of the things to mention is that those centers listed there are the ones meeting criteria from CCS as a cooling center. If you are a center and you're not there, please let us know. If you refer to places and you don't see it there, please let us know too, if the info is wrong. We'll try to keep that up to date as much as possible.
Yeah, that's I think maybe we should mention the numbered letter. I think it's 168 from CCS that goes through all the criteria to be a cooling center. So those of you that are new cooling centers maybe should go through the list to make sure you meet those qualifications and then notify the state. Joe Schulman, I think, is still the person in charge of that.
I just put the link to the numbered letter in the chat. So if anybody wants to look at it, that was a good thing. One other thing, I guess, if people are still staying to listen, those decisions are very challenging, and I think I'm curious to know what Krisa and MJ and the others are thinking about the use of amplitude integrated EEG in community settings. We used to discourage that, but I'm wondering if you're seeing more of that, if that's a tool that might be helpful for this really just this difficult to identify population.
Yeah, I find it, again, obviously the some of the other, like the Toby trial, use it as an entry criteria. We use it a lot on the babies that come to us, and we're not sure like whether they're mild or moderate. And so, because again, we know that so many of these babies have subclinical seizures. So I think some of these babies that are sort of on the fence and haven't yet become moderate, if you have AEG on, you're going to catch seizures that you would have otherwise not seen. So I think it's more use actually in the cooling center when we're making a decision. I think less useful maybe in a referral center. Because again, AEG, it's difficult to get those electrodes on. And again, unless the people at that site have a lot of expertise in AEG and seizure recognition, I think that can be problematic.
Mm-hmm.
Yes, I really wanted to agree with Krisa. We actually have one center. We actually are the neonatologists trying to manage those babies, but not at VMC as the cooling center. It's a smaller hospital. And even with the neonatologists actually managing it, but trying to put the leads on, trying to get started, it actually sometimes causing delay for actually initiating communication. I think it's the utility there is limited and it requires quite ongoing education, even just the nursing staff.
Yeah.
Yeah, thank you, everyone. I could maybe answer, there's a question about how we disseminate these tools to the community. Thank you for that question. I think this webinar actually is one part of the answer to that question. We are trying to disseminate this information as best we can, but certainly open to your suggestions. But we are definitely going to have this recording available publicly, freely to anybody, and there should be a link sent out to you shortly afterwards.
Because again, 60 to 80% of the babies that end up at cooling centers are outborn. So they're coming from smaller hospitals that may have only 1,800 deliveries. So knowing what the incidence is, 1 to 3 per 1,000 births, they're rarely seen these babies, and therefore there's a big challenge to screening and identification. So I think use of the algorithm with the sort of the time of when you're supposed to do the different tasks, I think is hopefully very helpful.
MJ, you're muted.
Thanks. I think that the cooling center should also be a route of dissemination to each of their referring hospitals, just so we make sure that they're covered. Because especially if a hospital isn't even used to delivering babies, they may not be aware of something like this.
I know we're over time already, but so thank you for our panelists for staying on. I think we could do just a few more minutes, and certainly if you have to go, anybody, please feel free. This is being recorded, so if you want to catch the last few minutes another time, that's fine. But there are just a few more questions we'll try to get to in the next 3 or 4 minutes.
So, Harry, does CPQCC has current data regarding how many babies are cooled in those centers, in whether they are fall into this 1 or 1.5 per 1,000 range in terms of expected encephalopathy or HIE? I guess there, and also give you a sense of which region are actually doing it and which region not. Of course, the incidence may be variable, but at least give a ballpark.
Yeah, we have some data. I can't present anything right now, but I know that Jochen Profit has already worked on some analyses, and I think maybe published soon enough. Yeah, we will try to get that out.
There's another question about the optimal timing to obtain the head MRI, MR spec study. I think one of you want to answer that. After cooling.
I think our practice is to do it, somewhere between 4 and 7 days of age. Sometimes, obviously, in some of these babies, because again, we see a lot of PPHN, pulmonary hypertension, respiratory failure is seen in about 22 to 25% of babies with HIE. And so often these babies are still intubated at that time, so they have to wait and get it. But again, MRI is done, somewhere between, 4 and 7 days are ideal, because if you get past 7 days, there's some pseudo normalization of some of the MRI findings.
Our practice is to do it usually within 24 hours of rewarming. So that's usually around day 4 or 5.
Yeah.
Our experience, I think one thing is our center's MRI unit actually does not having air. It's just 100% oxygen, because that really made this very difficult, and it's especially the babies who are still on oxygen. Even let's say we can willing to take those babies without ventilator, everything, but we really do not really feel very hesitant to expose them to 100% oxygen. I think for that, we have delayed many of those babies who has PPH and are on the respiratory support.
There was another question earlier on the chat. I think, Tom, there was a question about, can the COOL tool be initiated by nursing staff?
Oh, absolutely. Anybody with an internet access can just click on it. You can go to Google and it'll take you right to it. And you can start entering your patient information, or just make one up and check it out. Anybody can use it, but primarily nurses might find this useful because they may be the ones there on the front line at the time of birth trying to make a decision about whether to escalate this to a higher level of attention. And that may actually require calling somebody in, because again, in the community, you don't have in-house overnight providers always, and they're the ones who have to make that decision. You don't want them to decide that they don't want to wake up the doctor till the next morning because your 6-hour window will have closed. So if they go through this and they say, well, COOL tool says I got to wake you up, then we're more than happy to be that justification.
Maybe one last question. Priya, you want to, yeah, go ahead.
Yeah, and this was a question that was pre-submitted earlier. The question is, how much or what kind of support we need, neurology support do we need? Perhaps maybe MJ, do you want to answer that question?
Sorry, I was typing. What did you want me to answer?
What kind of neurology support is needed for a cooling program? And again, I would again refer people to the numbered letter, which states it pretty clearly. But again, MJ, why don't you detail all you can do for these babies?
So I was part of the committee that generated that letter, but we recommend at minimum that neurology be involved at least within the first 24 hours. And at our institution, we get involved in the first 2 hours because we have the neonatologist call us once the EEG has elapsed for about 1 to 2 hours, so we can say what's going on with the baby's brain rhythms. And then we're always involved with the family personally by the time we sit down for prognostication after the post-cooling MRI is done.
Yeah. At Stanford, we refer all of our cooling babies to a pediatric neurologist after discharge, and obviously to high-risk infant follow-up.
Yeah, the numbered letter states every infant undergoing therapeutic hypothermia shall have a consultation with the pediatric neurologist within the first 12 hours of life, at a minimum via phone, and then clinical assessment ideally performed in the first 24 hours of life. And then, of course, the follow-up is an important component there as well.
Does it say anything specific about neuromonitoring?
Tom, you're muted. You're trying to say something. Oh, there you go.
I said I should just share the screen. Here's the section on neuromonitoring as well. So there are certain, and then physician coverage. Here's the section on child neurologist, and then neuromonitoring. Infants shall undergo video EEG monitoring or amplitude integrated monitoring during cooling at minimum daily regular work hours for a video or a conventional EEG. Just let people read it.
Yeah, and we can share a link to that too.
Yeah, it should be in the chat.
In the post meeting. Oh yeah, it's in the chat.
And again, I think we have this new news that the incidence of seizures is higher during rewarming, so 25% or 24%. So.
All right, so I think we can wind down, and I'm very grateful for our presenters, panelists, really excellent information. And yeah, we definitely appreciate the questions that came in. Hopefully, I think we addressed all of them. If we didn't, that was not on purpose. So please, email, and we can try to get out that info to you as well.
Thanks, everybody.